Thank you. Could I just ask Jane Towson if you could unmute yourself? Thank you. Just to comment on that. I mean, 43% turnover in the home care sector. That must be a nightmare for your members to cope with that kind of level of turnover. Do you recognise that picture, and what do you think the main reasons are?
Thank you. Well, first of all, it's important to say that much of the turnover happens in the first 6 months, and that's true across care homes as well. And there is a very substantial number of people who've been in the sector for a very long time. As Oonagh said, the pay is a key factor. And I just ask you to imagine a clinical commissioning group saying to an NHS trust, we're only going to pay nurses for every minute that they're by a patient's bedside. And we're going to electronically tag them to find out when they're there. But we're not going to pay them when they're moving from one patient's bed to the next. We're not going to pay them when they're training. We're not going to pay them when they're supervised. We're not going to pay them when they're doing their CPD. How can you imagine the outcry would be in the NHS under those conditions? But that's, and on top of that, the NHS Trust would have to pay for all of those additional things by some miracle in its own way. That is what home care providers have to do, are expected to do every day. And it's that lack of trust that Raina talked about, you know, measuring care by the minute, paying for care, you know, the councils buy care by the minute, which means that providers end up having to employ by the minute. Nobody wants to do that, but it's the system that's wrong. And it's that feeling that Mel and Raina talked about of not being able to meet people's needs. People want to remain well and independently at home. They want to live the best lives they can, and we can support them to do that and save money for the health and care system. We know we can prevent admissions to care homes. We can prevent admissions to hospital. The number of people being admitted to hospital through malnutrition has increased by about 5-fold in the last decade. That could all be avoided.
So I completely understand and hear what you say about payment by the minute, and I think it's something we need to talk to ministers about, because when I was health secretary, I was told that 15-minute visits have been abolished, and it feels like they haven't. And so that's definitely something we need to look into as a committee. But can I just ask you, Jane, about the level of pay? Because in the evidence from Skills for Care, they said the average pay was £8.10 an hour. And Sue-Ann Balcom actually talked very powerfully just in the earlier part of the session about the importance of pay. It's not the only factor, it's not the reason you come to work, but it nonetheless does matter. What do you think that pay would need to rise to if we were going to get the level of pay sufficient to bring down that high turnover?
First point to make is that we do see a big difference between the self-funded part of the market, which is about 30% of the total, and the rest, 70% in the state-funded part. Some local authority commissioners are really trying to get the pay up, and we've seen levels around about £12.25 an hour. But you have to, in my previous role, when I was a provider CEO, I had a letter from a member of the public, and he said, I would willingly work in care, but I'm a married man with 2 children. I need to earn at least £2,000, £2,500 a month, which isn't a lot by any standards. I would need at least £12 an hour at the time, you know, and 40 hours a week. So it's also lack of security of income too on the large number of care workers, nearly 60% in home care, that are on 0-hour contracts. And I want to say too that you're probably aware that the United Kingdom Home Care Association calculates a minimum price for home care to be compliant with the national legal minimum wage of £8.72, plus compliance with the care regulations. And this year that's been calculated at £20.69 an hour. We've done a data collection of 139 of the 152 local authorities, and currently the median is only £17.20. We've got 13 councils paying less than £15 an hour. That doesn't even cover the national legal minimum wage and statutory employment on costs. And we believe it should be illegal for councils to purchase care at rates as low as that. 18 councils have not given any inflationary uplift to cover the 6.25% increase in NMW that we had in April. So when employers are paid by the minute on fee rates lower than £15 an hour, how can they possibly reward their staff properly for the skill and the dedication and compassion that you've heard about this morning?
Thank you. Let me bring in Professor Martin Green, if I may, and let me just ask you, Professor Green, your reaction to some of the evidence that we've heard so far this morning from people on the front line.
Well, I think, Chair, what we saw this morning was the professionalism, the dedication, the commitment of people on the front line. And I think all the people who gave evidence this morning were fantastic ambassadors for social care. And they also really underline the complexity of the role that they perform. So when we look at, for example, comparisons between social care and the NHS, we see that social care is supporting exactly the same people, but what we don't see is the same recognition in terms of public recognition or in terms of things like pay and conditions and training, for example. So I'm constantly amazed at how we talk endlessly about an integrated system of health and social care, and yet all the architecture of health and social care around the workforce is separate. So we have workforce strategies in the NHS, we're waiting for one in social care. We have Health Education England with a budget of 4.7 billion, £100,000 a minute spent on training in the NHS. Compare that with, I think, Oonagh's budget is about 21 million for Skills for Care. I also think that one of the things that's come out of this is this concept of an hourly rate. I think we need to move away from that. These are consummate professionals. They should be on proper terms, conditions and salaries, and it should not be about a paid job. It should be about a salaried profession, and we've got to move social care into that space.
Thank you. And can I just ask you about something that we haven't yet touched on, but I think is very important, which is the forthcoming changes in immigration policy. Now, at the moment, the average annual salary for a senior care worker is £23,700 in local authority run homes, and it's £17,600 in the independent sector. But the threshold in the new immigration policy, below which you can't bring anyone in from overseas, is £25,600. How is that threshold going to affect your members in the sector?
Well, it's going to have a significant effect. And I think one of the things the government need to understand is that we all want to have a homegrown workforce. And what we want to do is to aspire to a situation where registered managers are paid significantly more than they're currently paid. But we do have some reliance on overseas staff. And what I think the government has failed to understand is that they have not got their strategy right to make sure that we have enough people in the pipeline from in-country staff. So it would have been much more sensible if they'd had a transition plan which said we're going to enable you to bring some staff in from overseas until we've got our workforce strategy in social care right, and until we have enough people in social care from the indigenous group of people who live here currently.
So what do you say? The government say that you should just increase your salaries to that threshold level as a way of both increasing the stock of people applying from inside the UK, but also allowing you to bring people from overseas. What's your reaction to that?
Well, my reaction is it's not commissioned in that way. And I think Dr. Townson gave a very eloquent overview of the appalling way in which services are funded. And we could and we want to increase our salaries. And we want to see really professional salaries with proper training and development monies. And we would like to be absolutely far north of 25,000, actually. And, you know, when we heard this morning from colleagues who are managing care services, we saw how complex that role is. And it's certainly a role that is significantly above a £25,000 role. And so what we've got to do is we've got to get the commissioning of services to understand that. And we've got to have a long-term, and I think Dr. Townson again said this, we need to have a long-term strategy on social care funding so that we can really benchmark ourselves as a profession rather than just as a job.
So what you're really saying is a 10-year plan to go alongside the NHS's 10-year plan and a long-term funding settlement?
Absolutely. And in fact, you know, endless talk about integration. Why don't we have a 10-year integrated plan? What I'd like to see is some baseline skills and competency frameworks so that people can seamlessly move across the system from the NHS to social care, just as citizens do. You know, citizens aren't in a silo where they're dealing 1 minute with the NHS, the next minute with social care. These are interdependent systems. And one of the things that we need to understand is as demographic change hits us, we're going to need, first of all, more people to support people, and our current system with its straitjackets are not going to allow that. So we've got to get much more flexible in how we deploy staff, and we've got to get as well more staff who are able to move across the systems just as citizens do.
Can I come in there?
Yes, please do.
Yeah, so I think what we need to do is focus on outcomes on a system-wide basis, not just reduce everything to cost and minutes and get away from time and task. Look at a population level about outcomes and at an individual level about outcomes, and then do a sensible calculation of the cost and benefit of different models. We haven't even got a social care strategy, never mind a workforce strategy. We've got no idea whether we're heading for a more institutional approach at the moment. That's what it would appear, because all of the money is going into acute hospitals and care homes relative to home care and other community support. But citizens want to stay at home. They don't want to go into institutions. They want to stay in their communities, surrounded by the people that they love. And the support that we can give, we already support more than twice as many people at home as are supported in care homes, and about 8 times more than are in hospitals for a 4% of the budget that's spent on the NHS. So we need to stop looking at cost and start looking at value and the need to invest.
Well, thank you. We actually had a very interesting piece of evidence from a Danish expert who talked about the deinstitutionalization strategy that they've had in Denmark, which echoes some of those thoughts. But I've got lots of colleagues who want to ask you questions. So if I may, I'll move on to them. First of all, Taiwo.
Thank you, Chair, and thank you to the panel. My first question is, we've heard earlier from the previous panel about the negative perception of social care sector and the lack of understanding which the public have about social care carers, different types of carers, but also the roles of carers. How do you think this negative perception can be addressed? And do you think the pandemic has had a positive or negative effect on how the public views the social care sector?
Who would you like to answer that, Taiwo? Oonagh, hi.
So I agree that the perception of social care staff during this pandemic and the public awareness, I think, has never been higher. I think sometimes we lack the understanding of the diversity of social care and the diversity of people who are supported. So sometimes there's an assumption that social care is only care homes, and I think care homes are a really important part of social care, but social care is much wider. So we still think we could do more on that. I think the national recruitment campaign is one way that has been quite helpful, I think, in helping people to understand what skills and roles in care could look like. And I think the more that we can do that, the more that we can draw attention to just how skilled and how important these roles are in our communities. I think that would be much more helpful. And I think this pandemic is an opportunity to do that.
Thank you. And Jane?
Yeah, I agree that the pandemic has given voice to care workers and made their work more visible. The media, though, plays a key role here. Some have been fantastic, but we've been told that we can't get home care stories past editors unless we've got dead bodies or businesses closing. And we're trying to stop that. And in fact, in home care, we've been very successful at keeping people safe. Our largest member, who care for 28,500 people, have had 135 deaths. And yes, that each one of those is a person, and we're, traumatized by every one of them, but that's less than 0.5%. And therefore it's not news. So while we've been very successful at keeping people safe and keeping people well at home, nobody wants to hear the good news. So, you know, we really value the fact that you're listening to us today, because we can have an opportunity to get some of these positive points across.
Yeah, I think also, Taiwo, I think one of the things we should acknowledge, and Jane mentioned it there, is the amount of focus there is on the NHS in the media. So I was preparing for something recently, and I looked at my skybox and I saw inside the ambulance, GPs behind closed doors, the surgery unit, hospital. You know, this was all on one evening. All this media that is designed to give people an impression of the NHS. Well, we need the media to be more balanced, and we need to see some of the social care success stories championed in the media as well. So I think, you know, there is a role for the media in this too.
I agree that the media has a role to play. Just following on the previous question about, you spoke earlier about integrated care. Do you believe that England should have a fully integrated care model similar to Denmark, in which training, pay structure and career structure is integrated? And how do you think we can address the lack of workforce parity that we have with the NHS? Professor Martin.
Yeah, I think I want an integrated system, but what I don't want is an integrated structure. And I think far too much of the integration debate is all about organisations. So people talk about the NHS, local authorities, care providers. I think that misses the point. True integration is about the experience of the person who uses the service. And there are lots of good examples, the airline industry being one, where you can have lots of different players on the field, but they're all clear about what they're there to do, which is deliver a really good outcome for the person who uses the service. I think we've got to look at how we, should we say, reapportion some of the money in training and development. So at the moment, we've got significant amounts, £100,000 a minute, as I mentioned earlier, in terms of training in the NHS, but we have very small amounts for social care. And if we had a much more integrated career pathway, and we had proper sort of escalators for care roles as well as health roles, we could then see a much more integrated approach, and that would deliver, I think, better outcomes for citizens. And that is our focus. It's about the outcomes we deliver to citizens. To talk about organisations is really to miss the point.
Thank you.
If I can come
Oonagh, yes.
So I agree with Professor Green. I think it's around integration of experience. It's so that the individual doesn't feel the baton change between health and social care, that they're getting one experience. And I also think that we should never lose the value of social care in and of itself. It has value in and of itself, as well as in its interaction with health. And I think that focus on individual outcomes, on making sure that there's a similar level of infrastructure with social care and health. What we find quite often is that integration as a debate can be quite health-led, because there's not the same infrastructure in social care. And I think that when you look at countries where they have integrated structures, that they still have similar issues around parity. So I don't think structure change is I think it's a wider conversation than that, I think.
Can I come in?
Yeah.
Yes, please do.
Yeah. So I think we need to start with the needs of our people, and the needs are not all the same. So if you're a young person with a physical disability but full mental capacity, your needs are going to be different from a 98-year-old person with advanced dementia and frailty in a care home, or a middle-aged person with mental health issues that's resulting in self-neglect and your physical health suffering as a result. And then we need to look at the skills and competencies that the care workers need to support those different types of people. And as Oonagh said, some of those will be very much social needs, and others of them will be very much health needs. We haven't even talked about digital yet, but that's a huge emerging area where we need to get the workforce to the right level of skill and competency too. So I feel that I totally agree with Martin that we need to focus on the people receiving care and work in multidisciplinary teams on the ground. And in the best areas, that's already happening, with really good communication between those teams. And then the organisational form is irrelevant. In my previous role, we had a collaboration with Yeovil District Hospital, and their staff worked on our nursing home floor from 8 o'clock in the morning till 8 o'clock at night, 7 days a week. And apart from the difference in uniform, you would not have known that they were in different organisations, because the focus is on the people. And then you can train the whole multidisciplinary team around different cohorts of need.
Thank you. Just my last question, and that's directed at Jane. How do you think that the current issues in social care workforce undermines the sector's preparedness for the coronavirus?
Well, I think that quite a lot of emergency planning went in preparation for Brexit, but nobody had planned at local level, I believe, for a pandemic of this nature. We've learned a huge amount through this. In particular, personal protective equipment was quite a contentious issue, because normally independent providers have their own suppliers, but the suppliers were telling providers that the supplies were being diverted to the NHS supply chain, which is vehemently denied by the government, but that was the experience on the ground. Testing hasn't been available and still isn't for home care. We're at the bottom of the pile after care homes, after the NHS. And the guidance also, we've been the bottom of the pile. We've had to push really hard to get domiciliary care the recognition that it deserves in central government and in local government too. So I don't believe that the planning was adequate. I think we've managed, but we've been lucky in home care in that we've managed to avoid too much catastrophe. Somebody asked earlier about cancelled calls, and that has been an issue. Both citizens and councils have cancelled care calls. At times that's been as high as 10% of the total. And we've been worried all along about people needing support and care and not getting it, and their health needs not being met as a result as well. So there's a huge amount that we need to learn that we haven't got right.
Thank you. Dr. Luke Evans.
Thank you very much. My question is to Professor Martin and then to Jane, if that's all right. We've touched on a little bit about the structure, but a very dangerous thing from a politician to do some blue sky thinking. I'd like you to answer the question whether or not it's just we should carry on with the same system with the changes that you've talked about and an outcomes focus, or if I gave you a blank piece of paper, how would you design the care as a broad structure? We've got care homes, we've got domiciliary, we've got different nations across the world that have emphasis on state versus the family and the individual. Do you think what we are doing is right and it needs tinkering, or should we be doing something completely different?
Well, I think the reality is we've got the system we've got, and if we did something completely different, we'd have to start from year zero, and we'd have to do what Jane and indeed Oonagh suggested, which was have to start with people's needs. It would be a very broad system because it would take into account things like housing, access to a range of other issues like transport. And if you think about the prevention agenda, you would put in services much sooner. I mean, our entire system at the moment works on the basis of crisis intervention. And despite all the rhetoric about, stuff around prevention, it's very difficult, for example, to get domiciliary care into your home when you're at the point when it would be most effective. What usually happens is people wait for a crisis and then, of course, services go in. So I think if we were starting from year zero, what we would do is we would completely change the approach. We'd have a much more integrated approach in communities as well. So there would be a lot more of that. We'd also, I think, put much more power in the hands of the particular citizens, so they would decide what was the intervention that made the most difference for them. Many years ago, in a previous role in the 90s, I did some reviews of very expensive care packages in Lambeth. And one of the things that was startling was when I spoke to the people who were receiving them, incidentally nobody else had, and asked them what they thought of them. The majority of them said, well, I don't really want this. What I want is, and then they gave me a list. What was really interesting was that list was about things that were much cheaper, but actually made a difference to their lives. It was about support for carers. It was about interventions. It was about the flexibility of services. So rather than getting an assessment that says you will have your domiciliary care worker coming in for 30 minutes every morning at 9 o'clock, people wanted to be able to say, well, on Wednesday, I really want to meet friends, so I'd like a domiciliary care worker in for an hour and a half to help me prepare for that. So I think, one of our challenges as well is that often services are very much about the structure of the service, not the outcomes to the individual. And this challenge around flexibility is a really big one. What happens is services try and squeeze service users into them rather than responding to what service users need. And I think the flexibility issue would be high on service users' criteria of the things that are important to them.
Jane, do you have a comment? And then I've got a quick follow-up question to that.
Yeah, well, if I were in charge, I'd do things very differently. We know from scientific evidence that it's the social determinants of health that play the biggest role in people's long-term health, not acute healthcare. I would therefore view community-based support as preventative, part of public health, and invest in keeping people physically active, in making sure they've got enough food, ensuring they're connected to their communities, that they've got a sense of purpose, that they've got adequate housing, that they've got work. All of those things are what will lead to a healthy economy. So we can't afford to skimp on this. And Martin's talked about putting people at the centre. Well, I often observe that the self-funded part of the home care market points the way to how we could do things, because in that part of the market, the people are the commissioners. In my world, I'd probably abandon local authority commissioning. Sorry, local authority friends, but I would. And I would stop the micromanaging that goes on and allow people like Mel and Marlene and all of the people we heard from this morning to work with the people that they're supporting to agree and decide on, what can be offered within the budget. And I think it's unrealistic to believe that the state can pay for everything. But what we're missing out on is the preventative work, the lower level of need that doesn't necessarily cost very much in proportion to the amount that results in acute care if you don't do it. So I think we need to look at the cost of not doing things rather than the costs of, per minute home care.
Thank you. And just a quick follow-up on that. I'm interested in, from a GP side of things, when I've dealt with lots of relatives and families and individuals, where do you see the line drawn between what we need to do for the public and relatives on education regarding whether we move more towards it's the state's responsibility or more towards it's the individual and the family's responsibility? Because again, we heard last week that in Denmark, it's very much centered that as a society, they've decided it will be taken on by the state. On India and the subcontinent, it's very much it's the individual and elderly relatives live with the family. We effectively want to do both as well as have our working lives. Do you have an opinion on how the public's culture might want to change in terms of the perception of providing care? That's to you, Jane, first, and then Professor.
So I think we need to learn from other countries where they've managed to do better than we have so far. So in countries like Japan and Germany, they managed to engage the public in a meaningful conversation about the benefits to them. One of the things that people fear is that they'll have to leave their own home, that they won't have enough money to pay for care. So in those other countries, they managed to address those fears and explain that the measures that they were putting in place would give them more certainty for the future. And that doesn't have to be about the state paying everything. It could be that there are ways for them to save, to have perhaps tax relief on paying for your own home care, let's say. And we need to get rid of some of the perverse incentives in the system. So at the moment, because how property assets are put against the cost of care, local authorities would be inclined to move people into care homes because it means that they themselves, the local authority won't have to pay, when it wouldn't necessarily be the right time for that person to do that. They could have been cared for at home. So I think it's about showing the public. I think there's quite a lot of dissatisfaction already amongst the public, but it's showing them what solutions could you come up with that are benefit to them. And it's not just all about paying more tax, it's what's in it for me. That's the bit we're not doing.
Yeah, I would agree with some of that. And I think one of the challenges is about having an adult conversation about what the citizen should expect to deliver and what the state is going to deliver. Of course, if we had a conversation, Luke, exactly as you said at the start of this, we would also have a conversation about what bits of healthcare are free as opposed to what bits of social care are free. Now, if you look at who uses social care, pretty much nobody is using social care for any other reason than they have a health condition. And I think one of the other issues that's really interesting to unpick is the amount of ageism in our health system. And we've seen it graphically brought to the fore during the COVID-19 pandemic, where we saw really bad behaviour from the NHS around, for example, retreating from care homes so that they were left very much on their own. So interestingly, Every person who's in a care home should be the responsibility for their health needs of the NHS. How many of them got a shielding letter? Well, my research tells me very few. And that was because once you move into care services, people in the NHS seem to think, well, that's their job done, and they've handed it over to somebody else. So I think one of the challenges is that if we're going to have this public debate about what people pay for and what they don't, it has to be a debate which is about a whole system debate, not separating out particular bits, because actually nobody is in care for one reason. There are a multiplicity of reasons, some of which are health related, some of which are social related.
Thank you. So I'm going to move on to James Davis. I wonder if I could just ask our witnesses if you could just turn down the volume of your speakers a little bit, because we're just getting a little bit of echo. That'd be really helpful. James, over to you.
Thank you, Chair. My question relates to care homes and the impact of COVID. Clearly been a massive concern. And the access to testing now, how often are members of staff being given access to antigen tests, and how is the rollout of antibody testing going? To Martin Green and perhaps Jane Townson as well, please.
Thank you very much, Dr. Davis. Well, I think what I would say is it's patchy. The first thing to say is that if testing is going to be effective, it's going to have to be a rolling programme of continuous testing. And that needs to be for both staff and also for residents. I also want to see, for example, there are some tests, and there is one programme going on in Hampshire at the moment where you can get test results within about 20 minutes. Now, what we need is that testing rolled out, because that will also help us not only to be able to test staff and residents, but also to be able to test relatives who might want to visit. So I think we've got to get testing as part of an ongoing programme. It is not a once in a in a lifetime activity. It's something that needs to happen regularly. So I think also some of the testing regimes have been too complex. There are too many organisations that are involved, too many websites that people need to go to. You know, some websites are about specialist websites for care providers, then others are about general public access, etc. And I just think we need to have a much more clear, centralised, consistent and also regular approach to testing.
Thank you. So clearly that's pretty urgent, isn't it? As we fight the pandemic, yes. we need to roll this out. There needs to be leadership to make it happen.
Yeah, very much so. And this needs to be now.
Yes, yes. And to what extent are you aware of cases having come into care homes because of lack of access to testing, whether for staff or for residents?
Well, I think at the start of the pandemic, we saw people being discharged from hospital without tests. And of course, that is a major challenge because you might be bringing the pandemic into the care home. And I think one of the things we should acknowledge is that if you look at the residents of care homes, they are all people with several underlying health conditions. They're in the highest category of risk. And I think that was part of the problem at the start of the pandemic, that there was no acknowledgement of that, despite what the Chief Medical Officer said about 3 weeks ago, that they knew that people in care homes were at the highest risk. Well, that didn't translate at the start of the pandemic into a consistent approach to how they supported care homes, and also particularly the way in which primary care withdrew and some of the challenges around that. So I think we've learned some really tough lessons from this. And I hope also, it goes back to an earlier point I made for another question, we need to stop focusing on organisations. All the focus was on the NHS as an organisation. It should have been on the most vulnerable citizens and how we protect them, whether it's through social care or the NHS, or in the best of all worlds, a combination of both working together to ensure that people had the highest level of protection.
Thank you very much. And does Jane Townson have any perspectives on these issues?
Yes, so testing has never been seen as a priority for home care right from the beginning. So although it hasn't been reported, we also had people discharged from hospital to home care without testing. Because testing capacity has been limited, home care has been at the bottom of the priority list. So people receiving home care were never even on the list. At one stage, care workers were told that they could all have tests, but the practicalities of accessing them meant that it was, you know, very low levels. You mentioned about antibody testing. None of that has been available for home care. The pilots were all done directed at care homes. There's been nothing available for the large, and I should say that exactly the same number of people work in home care as do in care homes. 685,000 people nationally. It's half the workforce, but it's been largely ignored.
Okay, so
thank you. Sorry, James, so you're going to say something?
No, thank you, Chair.
I think because we're just getting very close to 11 o'clock there, we've still got Barbara, Paul and Dean who want to ask questions. So we've got lots to talk about after 11 o'clock. But what I'm going to do is I'm going to suspend the hearing now until 1 minute past 11 in memory of the victims of the Reading terrorist attack. So we'll have a very brief suspension and then we'll restart again at 1 minute past 11. Order, order.
The proceeding is currently suspended. 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 The proceeding is currently suspended.
Order, order. We're now resuming the House of Commons Health and Social Care Select Committee, and we're looking into issues around the social care workforce this morning. And I'm going to go over to Barbara Keeley for the next question. Barbara.
Thank you. I've got a couple of questions, starting with Oonagh. We've heard a lot this morning about the lack of parity of esteem for care staff compared to the NHS. And we've also heard about how care staff have stepped up during the pandemic, delivering end-of-life care in care homes, doing tasks previously done by district nurses in home care. Can you tell us, because Professor Green touched on this earlier, but can you tell us how much is currently spent per head on training for care staff and how that compares to training for NHS staff?
I think it's quite difficult to do the comparison with health staff. I think, as Martin Green said, the total amount, if you divide for social care staff per head, the 11 million that is invested in the Workforce Development Fund, it gives about £7.72 per head for social care staff.
That's a sort of staggeringly low amount. What on earth could be delivered for £7.72 per head?
I mean, it came up quite a lot this morning. I think that sense of having the need for more development and more clearer career progression, I think, for our care staff, not least because the roles are quite complex and very skilled, and I think it won't surprise anybody to know that from Skills for Care's perspective as the workforce and skills body, we would be advocating better development of the social care workforce and more opportunities for career development. And I should also say that given that we will need approximately 580,000 additional care workers between now and 2035, I think it's quite important that we start to invest in that and think about that now.
Yeah, but I mean, that's a staggering figure that you've just quoted. I don't think many people would understand how little is spent on the care staff when, you know, we're entrusting them during this really difficult time with those tasks that I've just outlined, when they're actually entrusted with end of life care for large numbers sometimes in care homes, when district nurses have stepped back and they're taking on those nursing roles in home care. It just seems unbelievably small, doesn't it?
It's probably important to point out that that's the amount that's spent from the public money, I suppose, or from the department. Employers will also invest in developing their own staff. We just don't know what that figure is.
No, but I mean, compared to public spend, which runs to billions, I think nearly 5 billion, Professor Green told us earlier. Okay, would on this issue, would registration or regulation of care workers help with the standing of working in care? Because we think it's very important. We've covered this morning to raise that standing. Martin Green talked about a professional salaried career in care. So would those be important aspects, do you think?
Yeah, I think Skills for Care definitely supports increasing the value status and the recognition and trust in the adult social care workforce, and employers definitely tell us that they see benefits of registration as a way to achieve this. And certainly a recent study in Northern Ireland with our equivalent in Northern Ireland has said that care workers feel that registration gives them more confidence. And I think people are asking whether we should start with registered managers, which I think we heard this morning. So I certainly think that there are a lot of employers out there that would see the benefits of registration in terms of having a defined workforce that we can increase the recognition of and the value, I think.
Yeah, I don't know if Professor Green or Jane Townson want to comment on that.
Yeah, I certainly, Barbara, I think it would be great if we had a proper approach to registering the social care workforce. I also lament the demise of things like the graduate entry scheme into social care. There is a really good one in the NHS. We had an excellent one, which was part of the Skills Academy for Social Care, which then merged into Skills for Care. But again, we lost some of the funding for that. And I really want to nurture our next generation of managers. And I think we saw the fantastic people who are managing and delivering social care in the first evidence session. And what we've got to do is we've got to start really attracting people to build careers in social care. And I would love to see the reinstatement. I think actually that we do have a scheme, but it's a very small scheme compared to the NHS.
As far as home care is concerned, the long-term goal, we believe, should be registration. But we believe if that's done in the absence of the other measures that we've talked about this morning, adequate funding, having a workforce strategy, having clarity about skills and competence for different roles, clarity about the training and national accreditation of training, it would be like putting an elastoplast on your knee when you've got a fractured neck of femur. Absolutely pointless, and could end up spending a lot of money and time without really getting the benefits that we need long term from developing the workforce in the way we've described.
I think I would just come in there if that's okay, Chair.
Of course.
To say that I think Jane's right. I think that isn't where you'd start. I think it might be where you'd end. But I think we do need a package, I think, of interventions that improve the value and recognition and support to the adult social care sector, and registration, I think, isn't where you'd begin.
Thank you.
Sorry,
Barbara, go on.
Yes, just one more question, really. Care providers have actually taken on additional responsibilities and, are still having to take extra precautions, infection control, spending much more on PPE in a lot of cases. I guess this is a question for both Professor Green and Jane Townson. How much do you estimate those extra measures are increasing costs by, and are care providers receiving funding from councils to cover those costs at the moment?
Martin, you go first.
Yeah, okay, thank you, Chair. Certainly, we are talking of hundreds of millions of extra pounds spent on this. And also, I want to commend on some levels, the government has put enormous amounts of money into social care, but they put it in the wrong place. And social care providers have not seen the £4 billion that's been invested. And local authorities in many areas have not transferred that money. We've got the Infection Control Fund, and now what we've seen is endless amounts of bureaucracy associated with it. So this is causing some serious issues, and we heard that from our first group of evidence givers this morning. But also in terms of where the other money has gone, this has not reached the front line of care. And there are some tough questions that need to be asked, first of all, to local authorities as to where that money's gone. But secondly, why the government constantly obsesses with putting money through a flawed mechanism. Local authorities are not a good way to deliver money to the front line of care. And I think after this pandemic, we need a long, hard look at what's local and why some things are seen as local, and also about the performance of some local authorities in relation to how they've supported care providers.
Thank you. Jane, yes, briefly, and then we better move on.
In April, we did a piece of analysis through an independent consultancy, and they helped us to calculate that the additional costs of COVID-19 for home care worked out at £3.95 an hour extra. And I already spoke earlier about our UKHCA minimum of £20.69 an hour, so that's on top of that. But we're only seeing £17.20 median coming through. And the additional funding for COVID-19 on the Public Accounts Committee yesterday, Catherine Francis stated that only 500 million of the 1.6 billion that was given by central government to local government has been spent, according to the records that are being sent back to central government. This is an absolute travesty. We've got 1 week until the end of June, and our providers have no idea whether the extra funding for COVID is still coming. And it's driven mainly by PPE costs, because we're having to use face masks and eye protection that we don't normally use, and the unit costs of those items have gone through the roof.
Okay, thank you.
Thank you very much. Paul Bristow.
Thanks, Chair. Just at the risk of not wanting witnesses to repeat themselves, I just want to clarify some of the things that perhaps Jane might have said, maybe Professor Green might want to comment as well. Would you say, Jane, that local authorities are not effective commissioners of home care services?
I think we have to see it in the context of central government funding for local authorities, which has been cut dramatically over the last 10 years. So they're trying to make their budget fit. They can't do what the NHS does, which is just spend with impunity. They have to balance their budget. And what they've done to try and do that is commoditize care. So they treat care workers like commodities to be passed from one provider to another through contracts, beginning and ending. And they also treat clients in that way too, because people bid for work through procurement portals. I think this is just such an incredibly wrong-headed way of going about the health and well-being of our nation. And I want us to think more about the impact on the economy of our health and our well-being, and to invest properly so that we come away from this time and task, paying by the minute, treating people, care workers and their clients like commodities.
What sort of weighting do you sorry, Professor Green, go ahead.
No, I was just going to say I agree absolutely with what Jane has said. And one of the problems has been that, for example, governments are absolutely steadfast about not saying that they'll ring fence certain things for social care. I also think that there is a vastly disproportionate amount of money between health and social care. And the points I made earlier about the health status of most of the people in social care, we need to see some transfer of money across the system. So I think there are some big issues here that we need to look at. First of all, we need to look at commissioning, because as Jane says, it's not fit for purpose. It's all about transactions. It's not about outcomes. It's not about showing that we are delivering things that help and support people. There's no incentivizing people to make sure that people are as independent as possible. In fact, we have a deficit model, so you get more money depending on people's dependency, not independence. We need to look at that. So I think a root and branch reform, and certainly also there's this obsession in politics with localism, and that's all well and good, but it needs to be justified. So this notion that somehow COVID is different in Halifax to how it is in Hertfordshire is ridiculous. So if there's going to be localism, I want a justification of why localities are doing things differently, and it should be based in the demographics, in the social makeup of their citizens, etc. And I think we've left far too much to sort of laissez-faire approaches to localism.
Okay. And Jane Townson, you said earlier that certain councils are charging as low as around £15 an hour, which obviously is suggesting that they're commissioning on price rather than value. But at £15 an hour, obviously some providers are taking this up. And are providing the service for this low cost. What is the consequence of this?
I think it's important to recognise that councils are monopsony purchasers, and they effectively coerce providers into buying at, bidding at these rates. And providers can't collude with each other, and they fear that if they bid higher, if they were to bid at the UKHCA minimum price, nobody would win any contracts. And this is just not the right answer, and it's the workforce and the people who receive care who are the ones who suffer. People talk endlessly about the workforce, but we never see anything addressed. I tell the Care Quality Commission all the time that the biggest driver for quality in home care is the commissioning practice. We've worked out that national minimum wage, £8.72 an hour, plus statutory employment on cost, so pension, national insurance, sick pay, holiday pay, comes to £14.89. Some councils are still purchasing care at £14.41 an hour, and we are condoning that. Central government's condoning that, local government is condoning that. How can that be right? That isn't even a legal level.
And I think Jane's right. We should also have some oversight of commissioning, and the Care Quality Commission should be, or somebody should be overseeing commissioning, because commissioning is one of the biggest influence on quality and outcomes.
Yes. Okay,
I had many battles on that, Martin, when I was health secretary, and I'm afraid I failed miserably. But I couldn't agree with you more. Dean Russell.
Thank you, Chair. And this question goes to Jane and Martin, if that's okay. The question I've got is, we've talked a lot about the bureaucracy, the challenges, localization, all of those things. It seems to me during the COVID crisis that one of the things that's really shone through is the fact that actually getting rid of a lot of red tape has made an awful lot of difference. And the idea of a sort of a single patient view of the approach of how we look at health, social care, all of those things are really important. I'm just interested to get your views on, if you had a choice now to say, look, we're going to cut 2 or 3 bits of red tape that have been around for a long time, from now on, what would they be, please? Perhaps to you first, Professor Green, if you don't mind.
Thanks, Dean. Well, I think what I'm doing is I'm preparing something which I will send to your chair and your committee, which is about all the things that have changed in COVID that we must not let slip back. Now, I think one of the things that's been really brilliant is the way in which, despite the fact there have been some challenges around testing, etc., the discharge from hospital process, which used to be endlessly complex with arguments between the NHS and social care about who was going to pay for what, we've managed to get through that, and now people are just being discharged, and there is an agreement they will be assessed after discharge. So it's a discharge to assess process. Now that can be so powerful in terms of how we deal with things like winter pressures. I've also put forward some proposals which are about one of the biggest challenges in social care, particularly residential care, will be occupancy levels. So I put forward some proposals that the NHS might like to guarantee occupancy levels within care homes. This would enable them to have access to some beds. Now, when we get past the pandemic, we will see a huge backlog in elective surgery. And what we could then see is we could see people having their surgery and then going straight into a care home for either convalescence, reablement, or the time before they go home, getting some treatment and support in that service. That would kill 2 birds with 1 stone. It would make the hospitals have a much clearer pathway. It would give the care homes money that would sustain them through this blip that the pandemic has delivered around occupancy, and occupancy is very much pivotal to the sustainability agenda. So I think there are some really important things that have happened in this pandemic. Likewise, some of the ways in which care staff have stepped up and delivered services that used to be delivered by a whole raft of other parts of the system, and we could consolidate that and acknowledge it and make it part of the funding process. So I think there are lots of things that have been positive. And what we must not do is we must not slip back to the previous point. And a point that Jane made earlier as well was about technology. And we have seen the use of technology. We've seen, for example, GPs doing what might be described as virtual ward rounds. We've seen technology being used as a fantastic support. We, for example, got loads of care homes on NHS Mail. This is a good way of transferring information so that people know who they're dealing with when there's a transfer from one system to the next. So I just think there are some really good things, and we must all now use our particular positions in the system to make sure that we don't slip back to where we were, that we use this as our platform for change.
Thank you. And last but not least, sorry to move everyone along, but we have oral questions starting at 11:30. Laura Trott has some final questions for the panel.
Thank you, Chair. Oonagh, you mentioned an important statistic earlier, which is that we will need an extra 500,000 jobs in the care sector by 2035. What do we need to start doing now to prepare for that number of people coming into the workforce?
I think it's everything that we've spoken about today. We need to change the narrative around care and help people see what a valuable and rewarding role that it is. I think we need to think clearly about those career progressions and the steps that we can take and how we start that now with people coming up through the education system. I think we do need a long-term sustainable plan for social care, for the social care workforce. And I also think we need to be cognizant of some of the impacts of COVID on the existing workforce, because that figure was calculated before COVID. And so we don't know whether that's going to have increased and whether we're going to lose really experienced staff. We know that care workers have been much more likely to die than the general population during COVID, and that's bound to have an impact. So I think we need to start planning for some of that now. And I think we need to realise that the social care sector is a significant contributor to the economy. It contributes £40 billion a year, and we need to start seeing it as a significant sector, employing 1.5 million people, supporting 1 million people a year, and contributing a significant amount to the economy.
Thank you. And what would the immigration system that supports that number of new staff look like for you?
So I think we know that around 17% of the current workforce is not British, and we know that within the current rules, the average salary is going to be lower than the threshold in the new immigration rules, and that care workers are not classed as a shortage occupation because they don't meet the qualification threshold. So I think my concern is that social care and providers are going to have to navigate the uncertainty of COVID in an already fragile state without a long-term plan or a long-term funding settlement, and if that is limited, if there's an additional limitation around ability to recruit from outside the UK, I worry about the fragility. I think there's a lot that's just unknown with COVID, and having some flexibility in the social care sector would be helpful. 85% of organisations in our sector are small and medium enterprises with fewer than 50 staff, and so if they are finding it more difficult to recruit, I think that's a significant challenge for the sector. So I think a little bit more flexibility would be welcome.
I think they could start by putting care workers on the shortage occupation list.
Yeah. I think also one of the things about social care is we are a 24/7, 365-day, service. So one of the things I think we could do is attract people who are currently not in the workforce, who've got the great values that would support social care, but might have, for example, other caring responsibilities. And if we could make sure that they're enabled to work, it might be not full-time, it might be very part-time, but they would bring a contribution. I think also we've got to look at the diversity of the workforce. So we are supporting people from every walk of life, from every minority community, and we need to reflect that in our social care workforce. So I think there are some big issues around how we make sure that the flexibility of social care workforce is appropriate to the diversity of the people it serves, and also that we make sure that we offer and give opportunities to lots of people who are currently a bit excluded from the workforce.
Can I just make a brief comment? In home care, the structure of the system means that we can't use the workforce that we do have efficiently, because the volume is fragmented across numerous small providers. So you quite often will get 5 different care organisations all in the same street in the same town at the same time. So I think there needs to be a think about how the market is shaped going forward to make the best use of the workforce that we do have.
Very helpful, thank you.
Apologies, just unmuting there. Thank you all. That brings this morning's session to a close, and I think we've actually had a fascinating and very important session. It feels like a session where we've been shining a spotlight on an area that isn't talked about nearly as much as it should be, but where there are some very profound issues which have come to light during coronavirus. But as Professor Green just said, things where we need to put things right for the long-term future, as well as just fix the short-term pandemic issues. So on behalf of the House of Commons Select Committee, I really want to say a very big thank you to Martin, Oonagh and Jane for their very powerful evidence this morning. And we will, of course, reflect very closely what you said in the report that we are hoping to publish around September time. So it'll be very helpful for us in that respect. Thank you to the technical team in the House of Commons for making this morning happen. And thank you to Laura Daniels and all the Select Committee clerks for their work in preparing for this morning's session. I declare the session closed. Order, order.
The proceeding has ended. The proceeding has ended.